Good afternoon, everyone. Today, I will be presenting the topic of is the molecular testing necessary in acute leukemia. I am truly grateful to the Thai Society of Hematology for giving me this opportunity to share this presentation with you all. As we all know, molecular testing can be implemented in acute leukemia. There are several types of molecular testing used in acute leukemia, from morphology to flow cytometry. Then cytogenetic analysis or chromosome study from blood and bone marrow cells to identify abnormality such as chromosomal deletion, duplications, or translocation. The next is the fluorescence in situ hybridization, of which by using fluorescent dye to visualize specific DNA sequences or abnormality in acute leukemia samples. For the mutational profiling, the reverse transcription polymerization reaction or RT-PCR is using for the detection of the presence of specific genetic mutations in acute leukemia cells. And recently, next-generation sequencing or NGS, a recently developed technique for analyzing the entire genomic landscape or specific parts of the genome, transcriptome, exome, or even epigenome, allowing for the detection of multiple genetic mutations or alterations. Molecular testing is also useful for disease classification, diagnosis, treatment planning, and monitoring strategies in acute leukemia. Regarding classification, the recently updated version of the WHO 2022 for hematolymphoid tumors emphasized the importance of defining genetic abnormalities in both AML and ALL. For AML, the fusion gene rearrangement, or specific mutation of a particular gene, such as NPM1, SEPA, are classified. For ALL, both of B and T cell ALL utilize specified genetic alterations for classification. Molecular testing is not only essential in AML, but also in AML. Recently, the advanced technology of NGS by using whole transcriptome sequencing in ALL can define the molecular entities with gene rearrangements that represent the specific group with different prognosis. As shown in both of B, ALL, and TLL here, the importance of molecular testing to classify the heterogeneity of acute leukemias is essential for treatment planning with the individual patient. Moreover, the molecular testing can discover new targetable genes that leads to establish new and novel therapy in cancer research field. The utility of molecular testing in diagnosis is well described, especially in AML. As we all know, the presence of the translocation A21 and translocations 15, 17, or even 16 with any blast count could be diagnosed as AML. Last year, the ELN and ICC consensus launched the newest version of ML classifications and emphasized the important role of recurrent genetic abnormalities to reduce the threshold of the percentage of blast count from 20% to 10% cutoff, except for BCR ABL1 fusion gene, because the blast crisis phase of CML should be carefully considered in the lower blast count. Moreover, the TP53 is the distinct feature of AML and MDS with increased BART. The molecular tool for determining the ovarian early frequency or VAF of the mutated TP53 is crucial. Furthermore, the myelodysplasia-related gene mutations defined by mutations of genes such as XSL1, BCOL, ESH2, LUNGS1, S3B1, and so on, without any chromosomal abnormality can be classified as AML with myelodysplasia related. Moreover, the specific group of the chromosomal abnormality is also mentioned in terms of genetic testing. The AML with myelodysplasia related is another distinct entity arising from different leukemogenesis requiring special selection for treatment, and prognosis is different from the de novo AML. A further diagram for the diagnostic scheme for AML from ICC or ELN 2022 highlights the importance of the molecular testing by defining the genetic abnormalities with a group of recurrent abnormalities, TP53 mutation, a specific group of gene or chromosome that related to myelodysplasia, and other diagnostic qualifiers such as the therapy-related, prior MDS or MDS/MPN, or germline predisposition. Before we delve into germline-related issues, let's discuss a large-scale study on gene mutation discovery in familial AML from 1999 until now. These genes can be categorized into three levels of the evidence. From the evidence of gene and disease association, as high, moderate, and emerging genes from basic research or inherited hematological syndrome. Additionally, this gene can also serve the different functions and so on, such as the DNA binding protein and transcription factor, another function of DNA repair and telomere regulator, gene related to the inflammatory reaction, and other functions. Interestingly, familial AML also show the association between genetic alterations and bone marrow failure syndrome genes. Over 70% of gene mutations in familial AML share the overlapping mutated events to bone marrow failure syndrome. From these results, molecular testing of the germline mutations in AML has an important role, especially in patients who have a strong history of multiple episodes of cancer. As the recommendation in the guideline updated here, a strong family history of cancer or multiple episodes of cancer, especially the cancer that occur at a younger age at the onset before 40 years old. By using DNA derived from tissue with a low frequency of somatic mutation, such as skin fibroblasts or hair follicle without occurring the variant allele frequency, patients with the bone marrow failure syndrome have a frequent onset of cancer and some of the family history, and then gene panel for testing usually represent the set of bone marrow failure syndrome mutation set. A group of genes could easily separated by organ involvement or pre-existing palate disorder. Variant scoring of the pathogenic and likely pathogenic are considered causative, and the results have an impact on the allogeneic stem cell transplantation in relative donor selection and health surveillance of patients and their relatives. For germline disposition of ALL, the PAC5 and IKCF1 mutated gene, as well as ETV6 or TP53 germline mutation in Down syndrome, have been reported. This table summarizes the germline predisposition genes in the several kinds of leukemia and MDS, with some of them having a specific or additional hematological abnormalities. The molecular testing enables the prognosis and treatment strategy, especially in AML. According to ELN or ICC 2022, only chemotherapy without allogeneic stem cell transplant can be considered in a favorable risk group. AML with FLT3 mutation, which is moved to intermediate risk, should add on FLT3 inhibitors with the standard high-intensity chemotherapy, while the adverse risk from the genetic mutated AML derived from the results of the molecular testing is highly recommended to consider allogeneic stem cell transplant after receiving achieve the complete remission. For the enormous evidence of the genetic alteration using the powerful molecular testing, as mentioned, ELN and ICC recommend that molecular testing or genetic analysis for the benefit of classification, treatment planning, and prognostication in AML individuals, as shown here. In our central experience on the impact of molecular testing in AML patients, FLT3 internal tandem duplication or FLT3-ITD mutation was the first gene to be explored. With a prevalence about 30% in adult AML patients, most of them were relapsed and refractory in over 80% of cases. with a median age of around 50 years old, and all of them was the normal chromosome detected. Treatment of FLT3 mutated AML with gilteritinib, which is the protein FLT3 inhibitor in the clinical trial, took part in 8 of 24 cases, with a median follow-up around 6 months. As you may know, prior to the era of FLT3 inhibitor in clinical practice of relapsed and refractory AML, the 1-year overall survival rate was around 10%. However, with the introduction of FLT3 inhibitor treatment, 1/3 of patients have seen an increase in overall survival rates up to 40% in just 1 year, just like in the last scale of multicenter clinical trial of the gilteritinib in relapsed refractory that have been approved in the AML treatment in relapsed and refractory setting. Additionally, a study on mutational burden of AML and MDS XXY in Thailand reviewed the 3 most common mutations to be FLT3-ITD, DNMT3A, and WT1, each detected in about 20% of patients. TP53 and advanced stage were also associated with poor prognosis. Our Thai Acute Leukemia Working Group, or TALWG, provide the data on the common frequent mutation of DNMT3A, NPM1, and FLT3-ITD from the ML patient that's registered in Thai Acute Leukemia Registry. The co-mutation in NPM mutant was also shown. It is important to note that mutations that occur in acute leukemia rarely occur as a single mutation. Most cases involve a bunch of co-mutated genes. This is where molecular testing comes in. At its least, the strategy of precision medicine with techniques such as the multi-parametric flow cytometry, PCR, NGS, that we are able to analyze the mutation at the molecular level to identify specific targetable genes that leading to optimal treatment. In fact, the knowledge gained from molecular testing has led to the discovery of novel therapies. For several decades, 7+3 chemotherapy remains the treatment standard and that stand alone in the some unmet need results, in particular genetic mutation. However, with the discovery of targeted therapies such as FLT3 inhibitor and IDH1/2 inhibitor, at least 8 new agents have been approved by the US FDA in just a few years. One of the powerful tools to derive the advanced knowledge of molecular testing is the MRD, or the measurable or minimal residual disease. By using multi-parameter flow cytometry, PCR, or NGS instead of morphology to monitor the treatment, as we shown here, we are able to detect residual disease at the higher sensitivity of the detection by using the molecular testing. Moreover, the addition of the treatment at the timing of MRD positivity but not over disease recurrence is theoretically feasible and can lead to durable remission of response. Large-scale studies have confirmed that MRD by flow cytometry and molecular-derived MRD using PCR and NGS method have a significant impact on survival benefit. If MRD negativity is confirmed by both techniques, the relapse risk is significantly lower than MRD positivity. This is also likely to have an overall survival advantage in the further follow-up study. Finally, molecular testing on single-cell analysis and sequencing by cellular separating technique and amplifying genetic contents of interest provide the precise and details on cancer study. This technique can assess intratumoral heterogeneity with bone marrow microenvironment interaction and also identify MRD which potentially create the novel therapeutic targets. In conclusion, molecular testing is essential as it provides enormous benefits in improving disease classification and prognosis. Yes, definitely. Providing treatment strategy in terms of the treatment for the selection or the addition of target therapy and monitoring of the MRD. And it also paved the way for cancer research and provides screening and prevention strategy for people who have a germline predisposition to acute leukemia. Thank you for your listening.